Welcome. My name's Ian Bowns. I'm a retired, for those who don't know me, I'm a retired public health doctor who's been involved with community contact tracers in Sheffield for about a year, I think. But for most of this year, we've been, I've been chairing a small group of us who've been looking at vaccination rates, uptake, and how we might support local groups to increase vaccine uptake and give people better information that's more usable to them about vaccines, benefits and any risks. Now, the purpose of this meeting is really twofold, I think. No, I'll rewind, threefold. Nick Payne, who's going to speak first in a second, and I, a few months ago, did an analysis of vaccine uptake and its association with deprivation and case rates. And we thought that as we approached the lifting of almost all restrictions, it would be useful to revisit that and see what the current position was. The second thing is that over the months, we've developed an online tool whereby people can look at data about their local community, what vaccine uptake is, and a number of other factors. And we haven't yet had an opportunity to demonstrate that to people so that people could make more use of it, make it easier for people to access it, and get some comments back on and requests and suggestions for any information we might add to that. The third thing we're going to touch on towards the end is some thoughts that Nick and I have put together about the positives and negatives, the risks and the benefits of relaxing the restrictions in the way and to the extent that it's planned to relax them shortly. So with that, I will hand you initially over to Nick, who will talk about the basic analysis that we've been doing before he comes back to me to demonstrate the online information that we've put on in the public domain. So Nick.
Thanks Ian. And I'm going to, as Ian said, we're going to have a two-person presentation. I'm going to start off and then Ian's going to continue. For those that haven't met me before or don't know me, I'm sort of three things, I guess. I'm a part-time vaccinator. I've been giving vaccinations since January, most weeks. I'm also a honorary professor of public health at the University of Sheffield and have been, but now I'm retired, obviously, a director of public health doctor locally. So I'm just going to share my screen to go on to some slides that I'll do, then I'll hand over to Ian sort of about halfway through. So just bear with me a sec. Just give me a call if you can see the slides. Can someone say they can see that all right?
I can.
Good. So this talk is about Vaccination Sheffield. It's about information. And it's going to be we're going to look at infections, immunisation, an update on COVID infections, immunisations and inequalities and other things as well. But those are all the things we could think of that began with I. So to start off with, where are we in terms of, we're going to cover quite a lot. So this is here really to people that look at this presentation afterwards and to remind me what we're going to talk about. But you'll see basically we're going to do a summary of COVID in Sheffield, variation in COVID case rates, the affluence and deprivation within Sheffield and how that might affect case rates, and then changes in cases and deaths recently, the delivery of the vaccination programme, and then we're going to go to Ian, who's going to demonstrate the vaccination data tool, and I'll leave the rest of what Ian's going to talk about to when Ian takes over. So I'm going to go up to the first half of these slides, points 1 to 5. So here we go. So this is where we are with COVID cases in Sheffield over the duration of the pandemic. So it starts on the left-hand side with the 1st of March last year and goes right up to where we are now in July of this year. And these are the number of cases that have been recorded. Please bear in mind that when we first started off looking at cases, we weren't very good at testing, so that the spike at the beginning, the little spike at the beginning, is almost certainly hugely more than it was, just we weren't testing very many people. But the thing to look at now is that we've been, up until sort of around about March of this year, numbers have been declining, but they have over the last, since mid-May-ish, certainly around that sort of time, been an increase in cases, and the increase is quite sharp. Whether that's slowing any signs of slowing down, it's too early to say. But there's just a hint that it might be, but we don't know yet. So that's where we are at the moment. We've had several peaks, but the peak that we've got in case number terms now is about the same size where we are now as we were at the beginning of the year, this year. In terms of where COVID's been in Sheffield, where it's been, as opposed to looking at the time course, this slide is slightly out of date, but it won't be significantly different in terms of the pattern now from what it was back in April. And it shows quite clearly that the darker areas, which are the areas with the higher COVID rates, the really darkest rates, 8 times the rates in the yellowy green areas. You can see that that in Sheffield there's a marked east-west or perhaps southwest northeast difference, and that there are quite substantially higher case rates in the north and east of the city centre, and that's quite important that we bear that in mind, because it also is important to see how vaccination rates compare in those areas as well. We'll come on to that, or Ian will come on to that later on. It's also a very similar pattern to the pattern of affluence and deprivation within Sheffield. And we'll have seen this before, we've talked about this before, but just the areas with the most affluent tends to be the areas that have the lowest COVID case rates, and the more deprived areas, that's the darker blue, purpley blue, mauve, whatever that colour is called, are in the north and east and city centre areas. So it's important to bear that in mind and look at how case rates not only have been varying over time, but also still vary by different parts of the Sheffield area. But what we want to look at, which is different now, is the COVID admission and the COVID mortality rate. So this slide, which is on exactly the same scale as the one that I showed you before, starting back at the beginning of the pandemic, going right up to the present day with the last few days at the far right-hand side, is looking at the number of COVID admissions that there were teaching to Sheffield hospitals. And you can see, well, first of all, going back to last year, huge numbers of people were being admitted. The spike was very, very high then. Then it dropped down over last summer, and we had a sort of two peak in November and then in around January this year. And since then, numbers have been pretty low. They've been as low as they were right back in the summer of last year or thereabouts, in spite of the fact that we've seen a substantial rise in cases. And I'll look at that in a bit more detail now, because I want to just look at the comparing cases with deaths as well. So 2 things to say about this. First of all, the top slide is more or less a repeat of the slides I've just shown you about the case rates. And we can see that there was exactly the same scale as before in terms of the time. Start of the pandemic here, where we are now here. There's the first peak, but we were undercounting cases then. And here are the peaks that we saw back in November and January. And the 2 lines are this light coloured line is people under 60, and the dark coloured line are people over 60 and over. And you can see right the way through that the two have mirrored each other until we get to now. Now, since the 1st of January, which is around about here, the lines have tended to depart. And what happened in the 1st of January, or the 6th of January in our vaccination centre is when we started doing vaccinations. And here we see at the moment that the rise in case rates that we've been looking at is a rise in people under 60. And there's been a small rise, but nothing like as big. There's been a huge difference between the two in the people over 60. So we've seen a rise in cases, but not only have we seen a rise in cases without a substantial rise in admissions, a small rise, but not a substantial rise, we've seen a rise in cases in younger people compared with older people. And when you look at deaths, exactly the same scale, okay, and there's the big peak that we saw at the start of the pandemic, and there's the two November and January peaks of last year and this year. Here's where we are now, right at the end here, scarcely any increase, despite the rising cases up here. These timescales are exactly the same, you drop down from one to the other. Deaths have scarcely increased at all. So that's a big difference as well. So not only is there a difference in age of people that are getting COVID, but also there's a big difference in the numbers that are going to hospital and mercifully the number of people that are dying of COVID. And this is just a final graph about deaths and COVID deaths. Slightly, well, they're all slightly complicated, but there's four lines on here. The red line is the weekly deaths in England and Wales on average over the period pre-COVID, 2015, 2019, and that's the period from beginning of the year to the end of the year, and that's right, isn't it? Yeah. So that's what we expect to see, with a slightly lower death rate in the summer, and then which has fallen from a higher death rate in the winter. That's commonly what you find. Last year, which is the blue line, a huge spike in the number of people of all cause deaths. So obviously this spike is due to the COVID deaths in March or thereabouts, or April, March. But and that's last year. But this year, which is the black line, the all-cause deaths is more or less the same. It's always a bit more spiky because it's only based over 1 year, not over 5. But the overall number of all-cause deaths is following the same line as it did, more or less, as it did before COVID. And this final bit here is the number of actual COVID deaths as opposed to all-cause deaths. There's the spike in January, dropping down now, and really no strong evidence of anything more than the slightest of increase in COVID deaths in the last few months, despite the large rise in cases. So there's an important lesson there about what's happening, and it's an important lesson about the impact of vaccination, because not only does vaccination reduce the number of people catching COVID and passing it on, most importantly, vaccination is very efficient compared with lots of other vaccines. It's very efficient at reducing the number of people that get ill enough to have to go to hospital, or even worse, dying of COVID. So that's all I've got to say about where we are in terms of cases and deaths and admissions and so on, and what's happened recently and so on. What I want to move on to now, and we're shortly going to hand over to Ian, but to look at vaccination delivery in Sheffield. Sheffield has relied quite substantially on primary care vaccination hubs, which are the sort of little red crosses you see on the map. And they've been spread fairly well around the city. They're not quite as well as so there are gaps, for example, around here, but and there are some areas that you might have thought, well, up here in Stocksbridge, that's quite a long way away, but that's good because it's got its own vaccination centre and so on. But those are the vaccination hubs, primary care network vaccination hubs. Also, Sheffield Arena. There's some pharmacies and other outreach carrying out vaccination. So that's the sort of main plan or the main delivery that's been happening in Sheffield. And here's the progress of vaccination in Sheffield. So the top line is the percentage of the population from the beginning of January, which is when we started, to now that have had the first dose. And we're up to 76%. 373,000 thereabouts have had the first dose, and the darker line are the people that have had second dose. So 57%, or over 279,000 have had a second dose. And this number will be going up to that one, hopefully. 76% and 57% at first and second dose is goodish, but it's not as good as some areas. And it's not, that's the Sheffield average. What we'll go on to see is how big the variation in Sheffield is sort of disguised by the average figure. So in some areas, it's much, much higher than 76% for a first dose. Some areas, it's much less. And Ian's going to talk about that. And I think the final thing that I wanted to show you about vaccination uptake, and these are some data that our friend and colleague Colin Angus has produced, is looking at, and this is national data, looking at vaccination uptake by age group. So let me just explain what's going on here. If you take what's being plotted is the percentage of the group, the age group that's been vaccinated. So 100% is the dotted line at the top, and no age group's got to that. Here's the time scale from January when we vaccinated, or actually December when vaccination started, right through to where we are, well, at least the end of June. And each different colour is down here, a different age group by age group 5-year periods, quintiles. So the 90 plus is the top line, and the 85 to 89 is the next one. This one here, I can't, 1, 2, 3, 4, 5, 6, 7, 1, 2, 3, 4, 5, 6, 7, it's just 50-odd-year-olds and so on. And what we're seeing is, and it's the same, we see it more clearly with the first dose, and we'll probably see the same data with the second dose as well, is that you get really high vaccination rates. This is the time it takes to actually do them, but by quite early on, and obviously because they were given priority, the oldest population age group got up to here. But the next, like this is the 90-odd-year-olds, but the sort of 75, 79s went up quickly, but didn't get quite to such a high level. And then you look at the 65s and 60s and the 50s, they all go up quite quickly. But as you get older, as you get younger, you don't seem to get to a vaccination plateau. And then we've got more data to come, as high as the 90-plus-year-olds or the 80-year-olds. And it's particularly worrying when you look at the youngest age groups, because all the indications are, and this is only indications, we'd like to have more data, but of course, time has got to elapse before this will happen. All the indications are that the youngest age groups are going to probably plateau at quite a significantly lower level of vaccination uptake than, it's pretty clear that's beginning to plateau now. And that one as well. This one is probably going to go up to here. Probably that's going to go to there, and etc. So it's possible that the 20-odd-year-olds aren't going to plateau anything like as high, half the rate of the older population. And that's quite a worry, because although they have less to lose, because they're less likely to be seriously ill and less likely to less likely to die if you're old, if you're younger. You're still at risk of getting long COVID, and you're still at risk of passing the condition on, not just to so the two things that vaccination does are importantly lost if you're not taking the vaccine up. So at that point, I'm going to stop, and this is the signal for Ian to take over screen sharing, because he's going to talk about and it's going to be a dynamic demonstration. He's going to be able to show it in real time of the data tool that he has produced, which shows you all sorts of stuff and all sorts of data about vaccination uptake, not only in Sheffield, but everywhere in England. So over to you, Ian, and I'm going to stop screen sharing now. Just now.
Right. I hope people can hear me and can now see a picture with 4 maps of Sheffield on it. Can I have some indication that this is working for everybody? Right, thank you. Now, I'm running this actually on my computer because it's just a little bit quicker than it is across the internet. But there is a website which is linked from the community contact tracers, I believe, Alex, isn't it? Where you can access this. Now, this uses largely uses data which are updated every week with the current totals of people vaccinated by in different areas, in different age groups. And what I've then done is allowed people to access it and look at it for their own age group by producing some maps and some graphs. And I hope that they're helpful to some people. But what I'm going to do is take you through each of the pages that are here and how you could look at it and how you could make use of that information should you want to. Now, this is the first one that we did, which was really around the split between people aged 65 and over having a first dose and people 65 and under. Now, the areas that you're looking at are what's called middle super output areas. They're census geographies that have been used in the census over recent years. They change periodically, but been reasonably settled recently. And what we've got is a map. So if you see the map top left, you have, can you see the text come up when I hover my mouse over it, or is that not working? So it says Uxbridge and Bradfield, 96% of people over 65 vaccinated. And you can hover over each area and you can zoom in to look a little more closely if you want to look at an area that you're particularly interested in. Okay, so we've got those percentages by small area. Now, the one at the bottom is an estimate of the number of people in those age groups who've not been vaccinated. So let's pick Uxbridge and Bradfield again. 76 people in Uxbridge and Bradfield over 65 haven't yet had a first dose. So you could actually use this to focus in on an area or look at your area and say, how many people have we got in those age groups who are or aren't vaccinated? And obviously there are larger numbers of the under 65s because it's a much bigger population in the first place. And those people were invited to be vaccinated later. So now, as time's gone on, the vaccination program has moved down, inviting increasingly younger age groups. And so I've added a series of maps for the current youngest 4 age groups. So we've got the 18th to 24, where it shows, like, stick with Uxbridge, 69% of the 18 to 24s in that area have been vaccinated. And if you go up the age groups, it's 81% of 35 to 39. But if you actually look at the darker areas, you'll see that it's only 26% of 18 to 24s between in Burn, Grieve and Grimesthorpe. So the pattern that Nick was alluding to earlier, and if you can go back in your mind to that image of affluence and deprivation across the city, you'll see that there is a trend, and we'll look at it a little bit later on some of the graphs I've done that are available here, towards the more affluent areas having the higher uptake and the less affluent areas having the lower uptake of vaccination for these age groups. Now, having familiarized you, I hope, with the basic view of these maps, I'll just go on to a couple more things that might find useful. I thought it would be useful for people in one area to be able to look at the surrounding areas. So, for example, here is a map of the entire region that Sheffield's in. So you can look at Sheffield, but you can then look over the border into, well, what's happening in neighbouring Rotherham or Barnsley to the north for various age groups. And this is, again, cover it, vaccine uptake, ages 65 and over, 65 and under, and the number of people. So it's the same data as the previous, the first 4 maps, but it now shows you that for the entire region. Obviously not so easy to see all of the boundaries because some of Sheffield's boundaries are outside Sheffield. Now, relatively recently, because cases were increasing, we thought it would be useful to have some sort of relatively up-to-date figures for case rates. So I've actually added a graph which brings us up to date with the latest case rates. So, and you can, again, as with most of these graphs, maps, you can hover over it and get more information. So the line that you can see there in a sort of green is Sheffield, and you can see the latest data, and you could move back along it to see earlier data and how Sheffield compares, for example. So it's obviously case rates have been increasing, but not quite to the extent they have in Northeast Lincolnshire or in Barnsley or Wakefield. But it's useful to get an idea, because if they're going up in a neighbouring area, there's every possibility that some of that infection will find its way into the northern part of Sheffield, for example. Now, moving on, the next thing I added was a way of looking at the percentage of adults who've had both doses of the vaccine, given that the current vaccines pretty much all require 2 doses. And you can do that, similar set of maps, but this time you've got Sheffield on the left and the entire region on the right, so that you can get some idea of how Sheffield's comparing. Now, the next few pages are a departure from maps, and we've got some graphs to look at some of the statistics in a different way. So, but sorry, I forgot, I'd got one last map, which allows you to look for the over 65s and the under 65s at how Sheffield compares with all local authorities. So there's Sheffield for the over 65s. It's got 90% uptake for the over 65s and 70% first doses for the under 65s. But you can see that some neighbouring areas like High Peak are at 84, Staffordshire Moorlands, Derbyshire Dales are higher. But if you look, for example, one feature that I'll show you in a second is that uptake rates are generally lower if you look at London. And that's not unusual for vaccination rates in general. They're often lower in London and in inner city areas. Now, using the same local authority data, or some of the same and some additional data, this is a rather different graph, but I think once you get your mind around it, you will see. On the left of each axis, we have the percentage of vaccine uptake. And each set of dots is a region and the local authorities within that region. So on the right, on the left in red that I've got my mouse over, that's the East Midlands. And if you move over to the far right, you will see that the grey is Yorkshire and the Humber. So you can find within that where Sheffield sits, which is at 55% second vaccination doses. And you can also do the same for the under and the over 65 age groups. So you can actually say, well, why is Sheffield at 70% doing so much better than, say, a notch better than Bradford, but not as well as somewhere else like Rotherham, who are 80. So it gives you some scope to look at another area and say, well, somebody else is doing better. What are they doing differently that might be that we might learn from and improve things here? Okay. And you can see the final point just illustrates the point I was making about London. This green group of local authorities is the London local authorities, and they generally tend to be lower than the other regions for both over 65s, under 65s, and for those who've had both doses overall. Right, I'm getting to the end, so bear with me. Now, the last two sets of graphs are slightly different. And these are what we call scattergrams, scatter diagrams. And basically, what we've taken is the small areas within the chosen local authority, so in this case, Sheffield. And along the bottom, we've got what's called the index of multiple deprivation. So at this end are the least affluent areas in Sheffield, and at the top end here are the most affluent, so Fulwood and Lodgemore, Bents Green, Ecclesall, Greystones, Dorham, Worlow. And on the left-hand axis, we've got the percentage of people vaccinated. And you can see there is a little bit of a trend that the more affluent areas are generally got higher uptake rates. But what I find more interesting is that there are areas which are as deprived as each other, where there are very different vaccination uptake rates. So again, there's an opportunity to say, well, we're at 82, 83% in Burngreave and Grimesthorpe. What are they doing differently in some of these other areas like Herdings, Leadless, etc., and whether we could find out what that is and change what we're doing, adapt what we're doing to try and increase the uptake. Now, the final one, because we know that has been issues.
Ian, just sorry to interrupt for a sec. Just before you go on, can you just go back one? Just in the light of what I was saying about vaccination rates tending to plateau at lower rates in the younger age groups. If the graph on the right is the same as the one on the left, except that it's for the under 65s. And what's clear from that is that the relationship, the steeper slope of the line, is that in that age group, the younger age groups, there's more of a relationship, a steeper relationship between affluence and deprivation in terms of vaccination uptake.
Yeah.
Thanks.
Yeah, but when you well, equally, I could say when you look, you could actually find that some of the lower uptake places are places that have got the highest proportion of very young people there. So they were the last ones to be asked. So they're not necessarily going to have as high an uptake as an area with an older population makeup. Okay. Thanks, Nick. Right, just finally, on the issue of ethnicity. Now, we've seen quite a lot of figures that uptake of vaccination has been different in different ethnic groups. Unfortunately, the uptake figures, as far as I can tell, are not available at very small areas by ethnicity. Now, that's partly because the population statistics for this are all based as estimates from the 2011 census. There's every likelihood that some of these are more than a bit out of date. But nonetheless, if we do take the total proportion of people living there who would identify as not being white, then what you get is a reasonably clear statistical relationship that the higher the proportion of people in ethnic minorities, the lower overall the uptake is. And that's evident from for both those aged over 65 and those aged under 65. Okay. Now, I've pretty much finished. The only other thing I would say is there's quite a bit of text there that should advise you on how to interpret this. And there's also a little page on what the data sources are and where you might want to go to get some more details about the nature of all these data. So what I think I will do, if it's okay with you, is just carry on with a few of our final slides, and then we'll have a discussion and come back to any points to do with this or to do with what else Nick and I are going to say. So if you bear with me, I shall go back and hope. Can people now see that I'm back with our slides? And this is the final point that I talked about earlier on, which is what do we think, and what's the future likely to look like with the relaxation of restrictions from next week?
Ian, I can only see the vaccination tool at the moment.
Oh, okay. I think it's to do with how I've shared my screen. So let me stop and start again. I've had this problem before, so apologies, folks. Here we go. That probably should do it. Yeah. Is that better?
Yep.
Now I've got what's helping. Now what I've done is I've got 4 slides here that talk about what do we think is going to help us in relaxing the restrictions and going to act in our favour to keep infections down and adverse outcomes down. What's not helping or what's hindering us, and then what do we think the likely benefits and the likely risks are of relaxing in this way? Well, things that are in our favour are the high vaccination rates, particularly amongst the highest risk groups of serious illness and death, and the fact that the vaccine has weakened, it hasn't severed it, like Mr. Johnson said, it's weakened it between infection and acute illness and death. Although, bear in mind, any increase in cases will still increase the number of people with serious illness, just to a lesser extent. Now, one other thing that's going to help us is the fact we're coming up to summer. And for example, relaxations come in on the 19th nominally, and schools break up on about the 22nd of July. So a lot of the spread that's going on within schools and some of the spread that's going on within other groups who would normally have a break over the summer, those transmission chains will be broken, or they'll be less powerful in driving case numbers up. Now, this is an odd one and a relatively small point, but the routine testing that we're doing may well become more useful over the next few weeks because the number of cases are going up, and it'll actually detect more real illness and fewer false positives. I think one other thing that's definitely likely to help is that a lot of people, irrespective of what the rules are next week, will still continue to take their own precautions, which they think they see as being proportionate to their risk and the commitment they want to make to reducing the risk for people around them. There are, however, a number of things that aren't helping. The Delta variant is undoubtedly more transmissible. There's some data from that Nick was hearing about only earlier this afternoon. Now, the cases, as we've seen, are already increasing, and that's before the restrictions are removed. We can only expect them to increase still further with a further relaxation. The message of personal responsibility rather than rules in almost all settings, I think almost certainly means that fewer people will take some of the simpler precautions in certain places. And some of the other people will look at the other people not taking precautions and decide why should they take precautions if nobody else is. There's also going to, I think, arise quite a bit of confusion. There'll be few legal restrictions, but individual organisations will keep variable precautions in place. As an example, I'm actually involved in Buxton Festival Fringe at the moment, and we have a number of venues, each of whom is taking slightly different precautions for their audiences based on their assessment of their venue, what their status is, and what they think is reasonable. And I think that will continue and possibly get more extreme, with some people keeping a lot of restrictions and others removing virtually all. Another point is that I think quite a lot of people have, obviously to me, anecdotally, already started behaving as if the rules have gone. They've started behaving last week as though it's next week. As we've seen also, the vaccine programme does seem to be slowing a little, and the uptake in the younger age groups does seem to be plateauing at lower levels. That will leave a substantial number of people susceptible to infection and potentially long COVID, if not to really serious acute illness. And there doesn't appear to be any clear strategy to protect vulnerable groups who haven't been vaccinated or in a sense cannot be vaccinated because a vaccine will be less effective for them. Now, there's some revised guidance just been issued for the extremely clinically vulnerable groups, but it's all a bit vague, and it contains some things like, well, you might want to avoid places where there are going to be people who've not had 2 doses of vaccine. Well, I'm not sure how you're going to know that unless you go through a train and ask everybody, have you had 2 doses? It's not going to be that practical in terms of the advice they're giving. Now, the positives from this is that we have to acknowledge that, and the Office for National Statistics last year did some estimates, and they said that some of the harm from the pandemic was most of the harm from the pandemic was directly due to the virus, but some of the harm will arise because of the consequences of the virus disrupting the NHS, reducing economic activity, and thereby impacting probably on the poorest people in society, affecting their mental and physical health, both in the short term and the long term. Now, removing the restrictions may help some people to come forward by giving them a message that things are open and, oh, I can go to the doctor now. But actually in practice, I'm not sure that's going to work, because if the health service has more COVID cases to deal with, in reality, it's going to be under more pressure. Some of the more arbitrary restrictions, I think, will be removed. There have been restrictions that are different between apparently similar sorts of venues, as an example. And people will get the opportunity to use their own knowledge to protect themselves when they're out and about, and assess the risk for themselves and modify their behaviour accordingly. The negatives, well, I think they're largely obvious. More cases will still mean more admissions and more deaths, even if we're talking about much lower numbers, thankfully. More cases will mean more long-term problems for those recovering. I mean, there are people here who've suffered longer-term problems from this. I think, thankfully, a lot of those problems do resolve over many months from the evidence we've got, but it's still early days. We still don't really know how long the longest term effects might persist for. More cases will, to some extent, reduce NHS capacity to deal with other problems. We've already seen it with some NHS organisations saying they've got more staff isolating, more staff off, now that there are more cases around. And there will also be some potential impact on hospitals, for example. If there are more admissions, there will be that little bit less capacity to treat other people. More cases and more positive tests is going to lead to more self-isolations, you know, people getting pinged. We've already got that, and we've got evidence that people are reacting to that by switching things off. I've got that in the wrong list. There is this very small point that isolation, while it's harmed, I would suggest on average most of us, there are some groups where it's actually helped them. So there's some evidence that a very small proportion of, say, children who'd been bullied or who have other mental health problems might actually on occasion have been helped by distance learning and different approaches, but they're in a minority. So in summary, going back to the first part of our presentation, the routine data on vaccination rates and case rates can be used to look at what's happening in terms of cases and the risk that you might face in being out and about, and vaccination uptake, and might be used by local organisations to try and improve the situation. There's quite a lot of variation, quite substantial variation, particularly across all age groups, but particularly, I think, among the younger age groups, with the more deprived communities having lower rates of vaccination, but having experienced over the pandemic the highest rates of infection. So it's an illustration of the old, what we've called in public health the inverse care law, by which those most in need often have the lowest access to healthcare. But the differences that we've observed can be used to compare similar areas and say, well, what are they doing that we could borrow from and improve what's happening on our patch. And our impression is that while many of the relaxations in regulations are beneficial, there are avoidable risks that it appears to us are not going to be avoided because of the way that the rules are being relaxed in one fell swoop and without any clarity in a lot of instances. So with that, I'm going to finish and stop sharing. And I know we've got quite a number of points in the chat, which I might come to if people are not wishing immediately to start asking questions. Although I think it might be easiest if I
before you do that, Ian, can I just make a couple of points that have occurred about the last few slides. While it is true that as we say, that high vaccination rates are in those at highest risk that is only true in highest risk according to age.
Yeah.
It is not true in relation to ethnicity or deprivation
No.
or affluence. Indeed, it's the reverse in those where the lowest vaccination rates are in the people at highest risk.
Hmm. Yeah. Thanks.
So it's only true in relation to age, not
yeah.
to.
Can I'm hoping that I've answered Susie's question about whether or not we've got more detailed data on ethnicity locally.
Yeah, that was
'Cause
helpful.
I think we're a bit limited in what we can do at that level. What you end up having to do is look at regional data or national data and say, well, I expect we're quite similar here, and make more use of your kind of local soft intelligence on what's happening. Janet made an observation about access to vaccine sites might be a factor. That was why we actually put the vaccine sites on the maps, so that people could see whether there was any obvious relationship between that. It's hard to prove it, but Jane Thomas has made the observation about the geographical mobility of people in inner city areas makes it difficult for primary care to keep up and make sure that they're actually able to invite people accurately. Yeah, if they've got the wrong address and the wrong phone number and the wrong mobile number, they're not, you know, the best system for sending out texts isn't really going to help. Tom, do you want to unmute and ask a question? Because I think people must be very bored with my voice by now.
Oh, okay. I mean, the question's in the chat, but it's to do with where do new variants come from? If the genesis of them is just to do with a number of cases that there is and the chances of variants emerging, then the rise in cases at the moment is amongst young people. And are they in some way protected from creating these new variants? Is it sort of like, or is it just a function of the fact that the rate, there's a lot of illness and COVID still about. So it's really a question about if we know anything about the genesis of the new variants, really, and how scared should we be?
I'm not. Well,
are you all as scared as I am?
I'm reasonably concerned, but I'm not a virologist, but it strikes me that it's a function of viral replication. The more times the virus gets copied, the more likely the mistakes are that are mutations, and therefore the more likely ones which favor the virus to be selected out. So the more infection around, you would generally expect the more likely we are to get new variants which favor the virus. The hope, I guess, would be that it favors virus transmission rather than the virus harming the host so much. But that may or may not come about. But I think the more infection there is around, the more likely we are to get new variants. Don't know whether somebody else knows much more about the virology than I do. Nick?
I'd agree with everything that Ian said, and it's not in the sense that the evolutionary pressure on the virus is primarily for it to be more infective, because that makes it more likely to replicate and so on. Not necessarily to be more to be more lethal, to be more harmful. In fact, quite the reverse. It tends, in the long run, for vaccines, for viruses, become less dangerous. But the other thing is that I have heard it said by virologists that there is some sort of upper limit on the number of variations in the genetic makeup that can happen, because after a certain point, it can no longer function if everything varies an awful lot, then it stops functioning. So there's not an infinite number of variant possibilities. There's only a few, but we haven't got there yet in terms of finding them.
Right. I don't know whether anybody else who's asked a question in the chat would like to unmute and ask their question. I've got Faraz about people adhering to guidance, and Brenda, is it about vaccine reluctance and pregnancy risk? Do you want, I don't know whether either of you want to.
Yeah, I'm Brenda.
Hi, Brenda.
Yeah, I just wonder whether, I mean, one or two people, younger people I've spoken to, have said, I don't want to get vaccinated because it will might affect my possibility of getting pregnant, or if I happen to become pregnant without intending to, it could cause problems. Now, I don't know how widespread this view is, but if it is widespread, there doesn't seem to be much medical evidence against it, or at least nobody's saying much. And the other thing is, I would expect that to account for some of the differences in ethnicity because of religion and cultures, who perhaps tend to have bigger families, as well as the affluence, but mainly the age, because if you're over childbearing age, you're not going to be bothered about that.
Mm.
But where this has come from, this thing about affecting fertility and so on, is unknown really, because first of all, there's no evidence that it's the case with this vaccine, but moreover, I don't think there's any vaccine, any viral vaccine or vaccine against infectious disease that affects fertility.
Well, originally, I know for a fact that they said if you could get pregnant or you are pregnant, don't take it part in trials. So if that's got round,
that's because
they didn't know.
That's because we didn't know. But since vast numbers of people have been vaccinated, and some of them have been pregnant and so on, loads of data have come out about that, and it's now a clear recommendation that people should be vaccinated if they're pregnant or might be pregnant.
Mm.
Maybe it's that's not getting publicised enough then.
No, I think you're right. Probably isn't, but it's actually very difficult to counter the first thing people hear very often.
Yeah.
Susie had a hand up. I don't know whether you wanted to comment directly.
No, I wanted to point out that Jane Thomas has been pointing out she wanted to ask a question about SAGE and BMA, and she's asked a few times in comments whether she can ask. So I'm just going to sort of say, Jane, do you want to unmute yourself?
Okay, thank you. Two related questions. So we've been covering this on Yorkshire Bylines quite a bit, but I think very specifically, something that's become unclear is, as we have shifted over from advice about who gets Pfizer and who gets AstraZeneca, has left some question marks about if there are actually enough vaccine currently to vaccinate all the 20 and 30-year-olds. So I think I'm also a volunteer at a vaccine centre. So I know that we shifted about 6 weeks ago from 25-year-olds to actually anybody under 38 could only have Pfizer. And I know I've noticed, certainly with independent SAGE, are now questioning if we've got enough vaccines for that cohort to be done twice. And there are some suggestions, and again, this is just us following stuff. So there's a very specific question about, is that going to have an impact on the very vulnerable 20 and 30-year-olds, which are obviously going to be a huge issue. The other thing was, obviously, what came out from the BMA yesterday was this big letter and real concern, I think, from many people in your profession, Nick, about the mixed messages from the government, and particularly about taking the foot off the brake too quickly. And Christina Pagel, who I think has been a real voice of reason and all stuff, sort of saying, you know, you can have herd immunity in two ways. You can have it via vaccine, or you can have it via exposure. And it looks as though we're going towards, with opening up, just exposure. And I think that's hugely concerning. And I just wonder, particularly if you've got observations, particularly about vaccine shortage, because I think that is quite significant, that move to, and then obviously this whole sort of, I think, debate that's going on amongst scientists and health professionals that seems to be slightly in contrary to what the politicians are telling us. Thank you.
Can I say about the supply first of all? Having been working as a volunteer in a vaccination centre since January, we've had some, like every week or so, we've had a bit of an anxiety about, well, are we going to get what we need and so on. And apart from a tiny amount of shifting of stuff, we always have. So there've always been scares, but it's actually, thankfully, not emerged. And I know that we've got 2 more vaccinations, 2 more weeks of vaccination sessions booked in the place that I'm working at, each with a couple of days, I think. And they're all second dose Pfizers for younger people. And so far as I know, we're assured that the vaccine will be available for those. So it's so far, I mean, you know, famous last words, because you can't be absolutely certain, but so far we haven't been hit by that at all. I think the mixed scientific messages is just a huge problem. A mixed, and I mean, I don't know what the answer to that is, because it's partly the press who will, whatever statement gets put out by somebody, will search high and low for someone else that will say something different and the opposite. But it's not just the press. There's loads of academic colleagues who seem to spend hours on Twitter putting stuff out, and I don't know why they do it. It doesn't seem to be very helpful at all. But you can virtually get any view you want if you find someone to ask.
Nick, can I just ask for your reflections on, I mean, the numbers of vaccines being given now and in the last few weeks seems to be less and fewer than previously. And I just, you know, is it a sign that the whole vaccination program is reaching some kind of steady state, or you know, because I think we still need to put our foot on the pedal with this, you know.
Well, I mean, we've several weeks ago, more or less everywhere finished doing first doses. Yeah. So that means that means that the period that occurred in sort of March, well, March onwards, March, April onwards, when we were doing first and second doses at the same time. I mean, if you see what I mean. Has passed, and we're just now to the second. We're just now on the second dose people. So that's part of the reason for reduction in the number of vaccinations. But secondly, there's that graph that I was talking about the uptake in younger age groups, and I think that's probably part of it as well.
Yeah.
Janet Harris, she had to. Has Janet had to go, or she just taken her hand down? She's been very patiently waiting, but has actually put quite a lengthy comment in the chat, which I commend to people about some of the issues. But Janet, have you had to leave? Looks like she has, but I just suggest people have a look. It's about the mobility of people and the need to do more work to promote vaccination in different areas.
And working at small area granular level.
Yeah,
I think that's absolutely right.
That's the strength of some of the groups that we've been working with. Nick, to pick up though on what you were just saying about stopping If your vaccine hubs stop doing first doses, and there are, and that's true, if that's true across the whole community, if there are still places with below 30% uptake in the 18 to 24 age group, when other places have achieved 80%, what that's done is it's made it even less easy for young people in the areas where the uptake's low to get a vaccine. If that's true, and you're speaking for you know, an area in the outskirts of Sheffield, and the only other observation I would add is that my wife's been, you know, volunteering in the car park at the local vaccination centre, and she came back last time with a comment from the staff that there were a lot. It was nearly all young people now, and there were a lot of no-shows. There were a lot of people who'd had an appointment who hadn't come.
Steve, what do you think about that?
Mr. Pagden?
Yes, in terms of what? Sorry, Nick.
And well, in terms, I mean, in terms of, it's essentially in terms of catch up. It's in terms of people that haven't had a vaccine but actually do need one, and how good is the system at coping with that?
Well, I've very little experience to comment on from personal observation, but I have to say I was a bit surprised that the place I was volunteering, the local PCN, had decided to stop doing vaccines, as it had gone very, very successfully, and could only wonder that they considered that the arena and you know, the big centres would have sufficient capacity to take up the youngsters. And certainly the evidence seems to be that that is the case, because my wife, who's a vaccinator, reports how quiet they are at the moment. So somehow the message must be getting out to the youngsters, but they're not really taking it up in the numbers that we would like. Quite how we address that, I don't.
That's what worries me.
One thing that does concern me on the numbers, of course, is with the new variant, is that 2 doses is very important. Yeah. Whereas going back a few months, 1 dose was quite important for the initial variant. That did the job. But now 2 doses is doing the job that 1 dose did on the original variant. So I think it's quite the messaging should be all about get your 2 doses. You know, that's very important. So it's not just get your 1, get the 2. Very, very important.
I mean, I'm quite concerned that centres are talking about closing down when there's a huge amount of need there. It's you know.
No, I agree.
Yeah. And we always said all along we're going to have to work harder and probably in different ways as a country to get the younger age groups.
Yeah. But it's all down to the. So I mean, what Janet's put in the blog in the chat is right. It's all down to really now focusing on low uptake areas, low uptake age groups, low uptake ethnic groups, all that sort of stuff. Yeah, they're the ones that deserve a lot of support now.
Right.
Just look at analogies with the screening programs and call recall and you know, trying to.
Can I use that as a very thinly disguised link to another in fact a question to people who might be wanting
Ian, could you let Abdirali come in? He's
sorry.
Yeah.
It's all right, Ian.
I was just about to do the same thing. Thanks, Karen.
I'm sorry, I couldn't see a hand raised or anything.
It's all right. All right, Ian. Thank you for all of you. I feel very optimistic than I was actually in January and February during that time.
Yeah.
And even I feel more optimistic when I heard what's going on in Sheffield, how Sheffield is better compared to Manchester, actually, when we compare to Manchester. And always we could find on the news that 9 borough of Manchester are rising, and this and that and this are coming down, and the other one is going up. We have been listening this information, getting this information of Manchester, the rate of infection rising and coming down throughout all this month. And when we look into the Greek Field's latest information and how Sheffield is doing, it gives you a lot of optimistic. And if I came into the community that particularly we represent, the Somali communities, we have a lot of difficulty, particularly they were more hesitant in getting vaccinations. And throughout a lot of work that has now come to end. Most of the elderly people who were mostly are not literate, now they got vaccinated. And we feel in a position of secure position now. And most of them elderly people, they have taken both vaccinations. What we don't know much is about the young peoples. But since the young peoples are connected to their homes and parents, actually, their guardians, we are hopeful that they might get vaccinated. And I'm sure we are in a good position, and I congratulate Sheffield and its people. Thank you.
Thanks very much, Abdi. So I think you know, Nick and I and others are feeling much more optimistic as well. What we're looking for, though, in the data and other things, is ways we can get an even better outcome in the future, I think.
Yeah.
Which does bring me to my question I was going to ask anyway, which is, I've tried to make some of the data available for small areas so that people can look at what's happening in their communities. I've tried to demonstrate how you can access it now through the web, that we've made it available. Is there anything else that people think they would like doing with that information that would make it more use to them? Because we've tried to do the coverage rates, how many people still need to be vaccinated, you know, how do you compare with other patches so that you can find somewhere to learn from. Is there anything we've missed? Susie?
I don't think it's been missed, but I just think it's something that we need to kind of keep going back to basics, and we need to continue to sort of, I think part of what sort of Rial was talking about is that one of the things that's been, I think, quite important for Marn is the fact that although we primarily work with people who are impacted by mental ill health and their families, we're sort of like, we've done a much wider spread in the last sort of like year and a half. And so we are being sort of signposted to people in the Somali community as an organisation with individuals they can go to if they want a conversation, if they want to be accompanied, if they want to be supported. And when you were talking about sort of like what can be replicated, it's across communities, especially different sort of like communities that are facing different types of disadvantage, and that sort of like includes, you know, white disadvantaged communities basically. The sort of like Sheffield's been appalling sort of like since 2010 at having the infrastructure of sort of like small community-based voluntary organisations that have got the resources, that have got the capacity, that have actually got sort of like investment in them to be able to kind of like be there and be the sort of like local sort of like, you know, community resources that can work at that granular level, which has been mentioned. And I think all of what's been done is good, but I think there's a level of which you need, in a sense, people to sort of like, you know, engage with people. And all the things that we're doing, which have been really wonderful in terms of having the messaging, you know, making it accessible, simplifying it, being able to do some things by Zoom, some things by WhatsApp. That's good, but almost like that there is an actual there is a seashore that we've come across that you need to have some rafts of people, rafts of sort of like, you know, the kinds of things that connects with the people that are sort of like, you know, least likely to want to talk to somebody in a Zoom group, want to talk to somebody in kind of like, you know, the traditional methods. So I think what we've done is good, but we need to sort of like try to look for those kind of like people, sort of like, you know, centered rafts of action change that sort of like, you know, take, you know, resources and support to people.
Yeah, it's back to what Janet was saying, isn't it? It's about having time to engage with people and answer questions, and accept uncertainty on occasions as well. So,
because what Riali hasn't said to you is that, I mean, he and Shimaki have probably sort of like done a lot, most of our frontline work. Yeah. When we've talked about the people that we've supported to go and get their vaccinations, there's an investment for some of those individuals at an individual level of maybe sort of like, you know, it could be sort of like, you know, 4 sessions, 7 sessions, you know, so many conversations, and there's lots of other support that's happening around that. Yeah. But we've been able to do that because we've accessed sort of like the public health sort of like resources to add to what we've got as a team. Yeah. And even though we're a small volunteer organisation, that to me makes a big difference. Mm. And I'm not presuming that all the different communities have got those resources in place, no. Even, you know, operating at a low level that we're operating at, and you know, it makes a massive difference. So it's not just reaching people, it's actually it's not just one engagement. It would be sort of like, could be 7 engagements, it could be sort of like 4 weeks, it could be something, it could take a lot of time. And it's actually just noticing that actually that's the reality of some of the most vulnerable and the most at-risk people that we're thinking about across all communities.
Yeah.
Carrie wanted to say something.
Sorry. Carrie, fire away.
Yeah, hiya. We did, I'm saying we, Bangreave and Furvale community contact traces, which was the arm, you know, working this side of the hill in Pittsmore and Furvale and down in Attercliffe. We had a Let's Talk COVID stall. This was before vaccines came in. This was around about the time when we were trying to encourage people to go and get tested. So we had a couple of stalls on Spittal Hill, and we were actually planning to have a stall, because we've worked in with Furvale Community Hub on all kinds of levels, bringing kind of fruit and veg, and also kind of going around the local shops with health and safety signage and all this kind of thing. So we're going back to have a stall sometime over the next week outside Furvale Community Hub, and we are going to field questions but we've got a whole lot of materials as well, and it's just useful, some of the information I picked up today, because I mean, I think it's absolutely reckless and criminal what this government is doing, and Monday is just sowing even further confusion, isn't it? But it's interesting actually, because I'd noticed that there was the information vans that are going around, and I just happened to go on the website and find out that they were down the road on Ellesmere Green last week. And they were supposed to be there from 11 till 3. I went down about 2:20, and the guys were, it's a council initiative, and the guys were all folding up the little, what do you call it? Not pagoda, what do you call it? The little marquee thing they'd put, that they'd had up, because they'd come under quite a lot of animosity from people. I don't know what had triggered it. Some guy had been suspicious of what they were doing. They were seen as outsiders coming in. There was a couple of Chinese guys there. They got a whole lot of racist abuse, and suddenly the whole thing had turned quite nasty. And they had actually been there 2 weeks before, and it had been fine. So I think certain communities and certain areas are very volatile, because, you know, I mean, we talk about deprivation and we're a bit glib about it and we use it. It means, you know, people are losing their jobs, people are losing their homes, you know, there's huge upset amongst people. And, you know, if they see kind of outsiders coming in with good intentions and good advice, sometimes they, you know, I'm afraid they get a bit of stick. And hopefully we're hoping, because we've done work in the area, that, and because we're going to listen and have some information and offer some help if we can, that we're going to take that kind of approach rather than kind of being didactic. But we're also going to say, because we had to before kind of refer to government guidelines, and I'm going to quite openly say that I think government guidelines are dangerous.
Well, there won't be many. Jack, do you want to go?
I think the council have really not done a terribly good job generally in relating to the communities, you know, just following up what Carrie said really. And they need us to, or they need the small groups, the people on the ground to to work with and do their work through those small groups. And they're only really just approaching us as SCCT to do some work after, you know, 18 months. We've been trying to get to engage with them, and now they're beginning perhaps to engage with us, but we'll see what happens. But perhaps, you know, through a meeting with the council, we could, you know, think about the sorts of things that that need to be done you know, that we should focus on from today's webinar.
Yeah. Thanks. We are at 5:25. I wonder whether, is that a natural pause in proceedings? In which case, I would like to thank Alex for organising, and Nick for doing quite a lot of the hard work on the presentation. And thank you all for attending. Otherwise, it would be Nick and I talking to each other again. Enlightening though that can be for me, but not so much for Nick. But I think try and finish on a little bit more of a positive note. There is more reason to be optimistic than there was 6 months ago, and certainly than there was 9 months ago when we lacked vaccines and things. There are things to be concerned and apprehensive about next week, but there are actually things that we can do, and a number of the people here are the ones who actually get out and do it on the ground, as opposed to me just sitting here and doing data things and trying to be useful. But I'll pick up in a second, Faraz, if I may. But I think there are things we can do, and you know, we can come back, and I hope some of the slides that we've done will be useful in saying, okay, yeah, I know that, I can do that, I can help somebody do that, I can modify my behavior so that I'm not a threat to other people or cause any conflict, or I can take more of a risk because I now understand that those circumstances are not as dangerous. The recordings will be available. I don't know whether we've managed to capture the chat as well, but I'll hand over. Faraz, do you have a question or a point? Quickly.
Yeah, I have a couple of questions.
Sorry.
One, yeah, I mean, I actually put them up on the chat, but they didn't
apologies.
Really
It's terribly difficult trying to keep track of everything. Sorry. Carry on.
First of all, this was regarding the odds of catching the coronavirus, even the Delta variant, which I understood from our last meeting, after double vaccination, is 1 in 16100. So 16,100. Have I understood that correct? Can you hear me?
Yeah, you were looking at the attack rates from it after you've had 2 doses of vaccine.
Yes, from the Delta variant.
That was our understanding of it, of those figures. Yeah, I think that was something that Steve had gleaned from one of the publications for the slides that I used. Yeah.
Okay, so that now the thing is, there's an issue of long COVID, because I'm hearing there is actually no diagnostic test for long COVID. But does it really matter if it's coming from the same virus in the first place, the Delta variants? And I mean, if I test, if I get a lateral flow test and I test negative, so I mean, does it? I mean, of course, the long COVID is like a symptom from the same virus. Is that correct? I mean, whether it's from the Delta variant.
The point about long COVID and diagnosis is that it's not something that you can diagnose with a test at the moment. Apart from anything else, it's a group of different symptoms of different severities and durations. So some people will still be ill, but will have some very non-specific symptoms to do with fatigue, and others will have very specific symptoms. People have had problems with joints and breathing difficulties and all sorts that are fairly specific. But there's no test that you can do with blood or anything, and it's not related to the infection that you've got at the time you've got the symptoms. So testing for the virus doesn't necessarily help to diagnose it. But it's quite real. I think going back to the figure that you mentioned about 1 in 16,000 or whatever it was, that's very much dependent on people becoming being symptomatic and tested in that series of data. And it may not include the people who will pick up the virus and pass it on and then eliminate it themselves, never get particularly ill, but may well transmit it. We do know, however, that the vaccines reduce transmission, as Nick said earlier. So they are pretty good at that. If we'd said a year ago we were going to have vaccines that were this effective at reducing serious acute illness and this effective at reducing transmission, we'd have just snatched somebody's hand off and said, give me it now, because it's actually not. We've got a good set of vaccines in terms of the impact they can have, but like every other treatment, they've got limitations.
Okay, well, obviously that I mean, I'm going to be traveling soon back to my HMO in Sheffield, so I will need to count on that, that I'm not going to become infectious and have any issues, because I've been double vaccinated, and I'm counting on that figure of 1 in 16,000. That means that to me is quite low.
Yeah, but the thing to remember for us from what we said before is that you've got an understanding of where the risks are. It's where there are lots of people in enclosed spaces for a long time. So you can modify your behavior to reduce your risk and any risk you might pose to them,
and
however small it is.
And I am actually hoping that behavior modification works, that my keeping sort of masked up when walking in communal spaces, corridors, and those sorts of things, and all the hygiene precautions and everything to make sure the surfaces are clean so I don't catch that COVID.
Get the windows open.
keep the windows open.
Keeping the building ventilated. I hope they are enough.
Take advantage of the summer. Anyway, I'm afraid.
Another thing is, okay, one is another question.
Oh, sorry.
What effect does isolating have upon a person's contagiousness? I mean, does that reduce it? Because if upon testing positive, if God forbid that happens to me, then I would have to isolate. What effect on my contagiousness would isolating be? Effectively, how would that sort of make me less contagious after isolation?
It's not the when people get an infection, they're able to pass that infection on, usually for a period before they feel ill, and for part of the period when they feel particularly ill. So isolation doesn't reduce your infectiousness as such. What it does is it keeps you away from people for the period where you are going to pass it on. So the sooner you know you're ill, if you feel ill, the sooner you take a test to confirm it, and the sooner you isolate. And that's the whole basis of contact tracing. And the sooner you tell people you may have been in contact with that you may have been infectious, they can isolate and they can avoid passing it on. So it will reduce, but exactly when you isolate in relation to your infection will affect how much your the transmission's reduced, if that makes sense. Somebody else might explain that better than I, but it will reduce the period. It will keep you away from people while you're infectious. That's the point of it. Okay, I think we've lost quite a few people, like most people, and I think now's probably a good time to wind up and say thanks again. And I don't think at the moment we've got another session planned, so keep an eye open on the website for anything we plan in the near future. And thanks again, Nick, Alex, and all of you for coming and contributing.